Yeah, that's my pleasure to be here. Thank you very much to organizers for inviting me here. It's always a pleasure to talk about tuberous sclerosis. I am going to talk in my presentation about the novel diagnostic criteria of tuberous sclerosis, about new options in epilepsy treatment, particularly preventative approach, and also about mTOR inhibitors in epilepsy and as a holistic treatment in tuberous sclerosis patients. The first description of a patient with tuberous sclerosis came from 1862. It was a report of Recklinghausen, who reported a newborn who died soon after delivery due to multiple cardiac rhabdomyomas. After this 155 years, we know much more about tuberous sclerosis, and the disorder is caused by the mutations in TSC1 or TSC2 mutations, and there are a lot of different inner organ involvements. We may observe a lot of benign tumors in the heart, kidney, brain, liver, but also those patients have a very high risk of epilepsy development, 80 to 90%, and mental retardation, 50 to 60%. We know that the protein products of TSC1 and TSC2 genes, tuberin and hamartin, are forming a complex which is inhibiting mTOR pathway, which is very responsible for the development of different tumors in this disease. And we also know that mTOR inhibitors like rapamycin or everolimus may inhibit this mTOR pathway, and in fact may significantly improve the outcome of the patient. mTOR overactivity in patients with tuberous sclerosis is producing different abnormal mechanisms, and many of them are responsible for the development of these devastating symptoms in tuberous sclerosis as epilepsy, autistic behaviors, and cognitive impairment. During the last tuberous sclerosis consensus meeting in Washington in 2012, there were some changes in the diagnostic criteria of tuberous sclerosis, and there was introduced a super criterion, the genetic confirmation, the identification of the pathogenic mutation. Now it is sufficient for the diagnosis of tuberous sclerosis even in the absence of clinical manifestations of tuberous sclerosis. If this genetic diagnosis is not available, we are still relying on two major criteria, or one major and two minor criteria. And among these major criteria, there are still some changes on the list done during the Washington meeting. So there is a long list, of course, neurocutaneous manifestations of the disease, and now we need to diagnose at least two non-traumatic periungual fibromas to make the diagnosis of tuberous sclerosis. There were also some changes in the understanding of cortical dysplasias in tuberous sclerosis, because cortical tubers and migration lines were also merged into one diagnostic criteria. And also there was introduced the number of two renal angiomyolipomas as one major diagnostic criteria of tuberous sclerosis. There were no significant changes in the minor features of TS. With the diagnosis of tuberous sclerosis, in particularly small patients, we have sometimes problems, because in patients below 2 years of age, we have only hypomelanotic macules. You can see from this slide the frequency of hypomelanotic macules in this group of patients is something 80%, 80-90%, and cardiac rhabdomyomas 83%. And there's a third diagnostic criterion, subependymal nodules on neuroimaging are seen in 80%. But the rest manifestations are absent in this small group of small patients. So really it is challenging sometimes to make the diagnosis in these small children. There are several causes of mortality in patients with TSC, and different age groups of patients. So in infants, the main cause of mortality are cardiac rhabdomyomas. which may cause obstruction of the blood flow and rhythm abnormalities. In patients in the first 2 decades of life, there is the growing subependymal giant cell astrocytomas may produce the death in this group of patients. In young females, progressive pulmonary failure due to LAM, and in adult patients, renal problems and renal failure may be responsible for that. There is a long list of recommended testing in patients with TSC. It was also recently amended by the TSC Consensus Conference, but we should particularly focus on the renal studies. We should do renal ultrasonography or renal MRI every 1 to 3 years in patients, and the on-cranial MRI because of surge of subependymal giant cell astrocytomas. Epilepsy is very important manifestation in patients with tuberous sclerosis. 71% of patients develop epilepsy within 24 months of life. Most of them have drug-resistant seizures. 80% of patients with epilepsy onset in the first year of life have mental retardation. Usually, of course, so far we treated those patients when they came to us with the seizures, which was relatively late. Which was late because in these cases, this treatment was very often ineffective, and many of patients still had drug-resistant seizures. On this graph, you can see the onset of epilepsy in patients with tuberous sclerosis. 60% of them usually develop first seizures in the first 6 months of life, 75% in the first year of life. So only 6% in our cohort of patients had first seizures at the age of 5 or more. When we analyze the association between the onset of seizures with the mental retardation, so you can clearly see that those patients who developed the first seizures in the first 6 months of life had severe forms of mental retardation. When we saw those patients with the epilepsy onset after 2 years of age, most of them had normal or almost normal mental development. So in total, 82% of patients with the onset of epilepsy in the first year of life had mental retardation. During the recent 10 years, we have more and more patients with the prenatal diagnosis of tuberous sclerosis. It is possible also because of a lot of ultrasonography studies done in the pregnant women because of the cardiac tumors. Multiple cardiac tumors are almost in 100% are associated with the diagnosis of tuberous sclerosis. If we have some singular tumors, cardiac tumors, the probability of tuberous sclerosis is something like 70%. When we do the prenatal brain MRI, we may confirm cortical tubers or we may confirm subependymal nodules. Sometimes there are some descriptions of the subependymal giant cell astrocytomas as well, even in newborns. This is a typical scenario of the first years of a patient with tuberous sclerosis. This patient was even with the prenatal diagnosis of tuberous sclerosis due to multiple cardiac tumors and the prenatal brain MRI. At birth, there were several hypomelanotic macules, and we did even the first EEG at 2 months of life, which was not a routine practice several years ago. And after that, we sent the patient home asking to come when the child has any seizures. The first seizures appeared at the 6 months of life. There were multiple partial seizures, but there were quite multiple per day, more than 50 per day. On control EEG, there were abnormalities, typical epileptic form abnormalities, and we started the treatment, but unfortunately with poor effect. These patients had controlled EEGs at 13 months, 16 months with epileptic form activities. Brain MRI confirmed multiple cortical tubers, and at 10 years, these patients had epilepsy and intellectual disability. We were quite disappointed with the number of patients who were diagnosed prenatally, but the outcome of our treatment was still disappointing. So we were thinking about the particular biomarkers which could help us to identify those patients with very high risk of epilepsy, and about the preventative treatment. So we know that the beginning of epilepsy, in fact, is preceded by the cascade of events which we can try to prevent, and preventing the development of epilepsy. In 2011, we published our paper about such trial, anti-epileptic treatment before the onset of seizures. At that time, it was completely for, the name, the word prevention of epilepsy was completely not existing in the area of epileptology. We compare, so the concept of the trial was that those patients with tuberous sclerosis had cortical tubers. Many of them are epileptogenic, producing epilepsy, seizures. If the seizures are not effectively treated, we may observe drug-resistant epilepsy and intellectual disability. Our concept was to treat with vigabatrin these epileptiform abnormalities on EEG, typical EEG as we can see in patients with epilepsy, in order to prevent the development of seizures, drug-resistant epilepsy, and what was our main target, intellectual disability in these patients. In the paper, we compared two groups of patients, standard care group with the preventative care group. This standard care group consisted of 31 patients who historically were treated in our site with very early diagnosis of tuberous sclerosis, prenatal or during the first 4 months of life. They were followed until 24 months of age, and in this group we saw those 9 patients who hadn't developed any epilepsy. Their development was completely normal, and 22 of them developed epilepsy, 71%, and 48% of them had intellectual disability. In another group, preventative group, we had 14 patients with similar diagnosis made until 4 months of age, and these patients were screened with electroencephalography. This study has been done every 4 to 6 weeks since newbornhood or since the enrollment until 24 months of age. And when we observed typically epileptiform activity, we treated them with the standard treatment in epilepsy in tuberous sclerosis. We had 4 patients who had normal EEG throughout 24 months, and they developed normally. They were not treated, of course. And 10 patients developed epileptiform activity, so they were treated. They were put on treatment with vigabatrin, and up to 24 months of age, 4 patients didn't develop epilepsy in this group and had normal development. 6 developed epilepsy, even if they were treated. And in 2 of them, we had observed intellectual disability of minor stage. The comparison of these 2 groups is in this table. You can see that it was exactly the same percentage of patients treated in both groups. In the standard group because of the seizures, in the preventative group because of the abnormal epileptiform activity on EEG. Interestingly, at 24 months of age, in the preventative group, we were able to obtain normalization of EEG in 8 out of 10 patients treated exactly at 24 months of age. Here, in this standard care group, these patients in this group, we were only obtained normalization of EEG in 2 out of 22 patients. We had a smaller number of patients with drug-resistant epilepsy. Most of our patients with epilepsy were seizure-free at 24 months. And we had a better IQ score at 24 months, and we had no patients with moderate severe forms of or profound forms of mental retardations in the preventative group, comparing to 32% of patients with these forms of developmental disability in standard care group. So the concept of our treatment, so normal history of epileptogenesis in patients with tuberous sclerosis is this way. We have usually normal EEG up to first 2 months of age. In the end of the second month of age, in about 70% of patients, we may observe some spikes, which evolve into multifocal spike and wave complexes, lasting longer and longer. And at this stage, sometimes we may observe some subtle focal seizures, which are at the beginning are very short, and if they are overlooked easily, which may be a case, in particular in young families, and we may observe generalization and generalized activity, hypsarrhythmic pattern, and infantile spasms. Here you can see just the clip done by the parents. There are some just focal seizures. It's not even generalized that the child is able to move the eyes with the, you can see here. So it is a typical beginning of the seizure. Sometimes it lasts even shortly. So we are going to change this process. So we are going to treat those patients with multifocal spike and wave complexes. And in a relatively large group of patients, we are able to get the normalization of EEG, which on a longer follow-up enable us to withdraw the drug. And we have now the follow-up studies of these 14 patients and even more. And in some of them, still, we may observe abnormal EEG, some focal paroxysmal activity EEG, but these patients have no seizures, and they even may not need any anti-epileptic drugs. So in 2012, there were some European recommendations that all those patients with early diagnosis of tuberous sclerosis should get this EEG follow-up every 4 weeks in the first 6 months, and every 6 to 8 weeks thereafter till 24 months of life. And treatment should be initiated in infants and children within 24 months of life if ictal discharges occur with or without clinical manifestations. I think it was a very important change in the treatment of epilepsy in this group of patients. So at least the experts in tuberous sclerosis were convinced that we should monitor EEG and we should treat those patients preventatively because of the very poor outcome of this cohort. Now, since 2013, we have a large European project, EPISTOP, and we have 2 aims in this project. One, it is just the comparison of these 2 approaches, treatment approaches in epilepsy and tuberous sclerosis, this preventative treatment and the traditional one. But there is also even more interesting aspect of this study, because we have for the first time a possibility to analyze, to assess the development of epileptogenesis, the evolution of epileptogenesis in patients before seizures, because in this group of patients, in these newborns with very often prenatal diagnosis, we are able to collect DNA, the blood from these patients, and observe during 24 months the differences in the expression of genes and proteins in this group of patients on the development of epilepsy. We have 101 patients enrolled. The enrollment phase is finished now, and we have a long list of different partners in the study. There are 5 basic science labs in yellow working on different aspects of this molecular analysis of these proteins and genes. We are collecting the samples at enrollment, usually in the first 4 months of life. Most of those patients have collections in newbornhood. The second collection is at abnormal EEG. The third collection is at epilepsy onset. And the last, 4th collection is at 24 months. And we have a set of different molecular studies which should be done in this group of patients. And really challenging is the the combination of this computational analysis of the results we are going to obtain. So it's a challenge. Just last year, there was also an American paper from the group, it was a multinational study done in several centers in the United States, and the authors also confirmed the electroencephalography as a good biomarker for identification of patients of high risk for the development of epilepsy. And they suggest to make the similar recommendation in the United States to follow the EEG and to identify those patients, which may be a basis for the potential preventative treatment in these patients. So in December last year, during American Epilepsy Society, it was declared also the beginning of the PREVENT trial. It is an American trial for prevention of epilepsy in tuberous sclerosis using vigabatrin. And there are 7 sites involved in this trial, and they are going to use vigabatrin and to assess the efficacy of this preventative treatment. So prevention is possible in tuberous sclerosis, prevention of epilepsy is possible in tuberous sclerosis, and I believe that there are also some other groups of inherited disorders with very high risk of epilepsy and very poor outcome, which may get benefits from the preventative treatment. We only need to learn more about the natural course of the disease, about natural course of epilepsy, and this treatment may be also implemented in these cohorts. Let's talk about mTOR inhibitors in tuberous sclerosis. The introduction of mTOR inhibitors in tuberous sclerosis changed the life of patients with tuberous sclerosis. At the moment, we use these mTOR inhibitors for the brain tumors, for renal tumors, and for epilepsy. We have 2 mTOR inhibitors in practice. Everolimus is the only registered mTOR inhibitor for tuberous sclerosis. It is registered for subependymal giant cell astrocytoma, which are not amenable for surgery, for renal angiomyolipomas in adult patients, and for drug-resistant epilepsy and tuberous sclerosis. Sirolimus is not registered, but sometimes used in some countries where everolimus is poorly available. We know, and we knew even before everolimus introduction, that it might be effective in renal angiomyolipomas, because there were some casuistic reports 15 years ago about the use of sirolimus in patients with the renal angiomyolipomas. So if you are going to treat subependymal giant cell astrocytomas, we need to describe what exactly the SIGA is. So during the recent, also the Tuberous Sclerosis Consensus Conference, there were discussion about the definition of the SIGA. It is a tumor located near the foramen of Monro with documented growth, usually at least 5 millimeters in diameter, and most of them are gadolinium enhanced, but not all of them. In our series of 64 operated SIGAs, the average age at surgery was 10 years. 27 patients presented with acute hydrocephalus, and in 13 patients, the hydrocephalus was the first sign of tuberous sclerosis. 15% of patients had bilateral brain tumors. In 5 patients, tumor regrowth was observed. In 4 of them, there was documented partial removal. In 1 of them, we believe that it could be subtotal surgery, not total surgery. There could be observed also some SIGA complications in these patients. So the persistent blindness, which was documented in 2 patients. It is usually related to the prolonged period of increased intracranial pressure, when we really overlook the beginning of this increased intracranial pressure in these patients. Hydrocephalus requiring shunt implantation was a case in 20 patients, and persistent hemiparesis as a result of surgical intervention was documented in 14 patients. Now we have mTOR inhibitors, and the first report about the introduction and of mTOR inhibitor for SIGAs was done by David Franz from Cincinnati. He reported 5 patients with subependymal giant cell astrocytoma, and these patients were treated with sirolimus. David Franz reported the 65% reduction of astrocytoma volume in these patients. It is interesting case presented in the same, reported in the same paper, just showing how the tumor is dependent on the mTOR inhibitor treatment. This is the baseline scan, just demonstrating the tumor, the large tumor. This is the scan after 2.5 months of therapy. And after 4 months break in the therapy, you can observe the regrowth of the tumor. Again, the patient was put on the sirolimus treatment with the regression of the tumor. So we now know that still the treatment must be maintained probably all life in these patients, otherwise we may observe regrowth of the tumors. After this initial report, there was another study from Cincinnati, 28 pediatric patients with subependymal giant cell astrocytoma. They were treated with everolimus this time for 6 months, and everolimus treatment resulted in tumor reduction of at least 30% in 75% of patients. The tumor reduction was visible within 3 months of treatment and was sustained on treatment. In some patients, it was interesting observation that everolimus treatment resulted in the decrease in seizure frequency and improvement in the quality of life was reported by parents. After this initial report of 28 patients, there was a larger study, EXIST-1 study, which also documented this beneficial effect of mTOR inhibitors treatment in the SIGA. There was a group of 117 patients who were treated with everolimus, and in this group of patients, at least 50% reduction of the tumor volume was observed in 35% of patients. Here you can see the history of the scans, of MRI scans on follow-up in one of those patients. Interestingly, also in this study, there was a group of patients who had a coexisting renal angiomyolipoma, and these angiomyolipomas were also assessed in this study. There was a group of 44 patients with coexisting renal angiomyolipoma, and as you can see, 53% of those patients demonstrated decrease, at least 50% decrease in tumor volume on the treatment with everolimus. So the response rate of renal angiomyolipomas was even better than the response of the brain tumors. Now, just last year, there was published the report on the long-term use of everolimus in this EXIST-1 study. And as you can see on the graph, this black line is showing the percentage of patients with the at least 50% reduction of tumor volume, SIGA tumor volume from baseline. And it was sustained response obtained in this group of patients on treatment. Something like at 50% response was sustained. The response of the renal angiomyolipomas was even better because, as you can see, during these 4 years of follow-up, the response of the renal angiomyolipomas was at the level of 85%. It is interesting to observe the safety of the drug of everolimus on longer follow-up. And you can see that the incidence of other adverse events decreased with the longer follow-up, with the most frequently reported adverse events as stomatitis and mouth ulcerations So from time to time, it was necessary to stop the treatment for a few days, but afterwards, it was possible to continue the treatment with everolimus in this group of patients. Response to everolimus was similar both in TSC1 and TSC2 cohorts. After the introduction of mTOR inhibitors, we had to discuss also about the changed management of the SIGAs in this group of patients, because we had two options, pharmacological and surgical treatment. Screening protocols haven't been changed so much. There is a change that after 25 years of age, there is no need prolonged treatment because there are very few patients who develop SIGAs after 25 years of age. The question in which patients we should use mTOR inhibitor or surgery. So urgent surgery should be carried out if we have symptomatic patients, symptomatic hydrocephalus. And in the new diagnosis and asymptomatic SIGAs, we have two options. So surgery should be particularly considered in smaller single tumors in absence of other TSC-related comorbidities, and mTOR inhibitor especially should be used in large tumors, in recurrent tumors after previous operations, bilateral or multiple lesions, or with other significant TSC comorbidities. Epilepsy and mTOR. We knew from animal studies that mTOR inhibitors may prevent epilepsy in transgenic mouse models of tuberous sclerosis. If mTOR inhibitors were applied very early treatment, rapamycin was able to prevent the development of epilepsy in these animals. And when was used as a late treatment, we could observe suppression of seizures and prolonged survival. The first documented use of mTOR inhibitors in epilepsy in tuberous sclerosis came from 2009. It was the report of a dramatic improvement on treatment in a girl with drug-resistant epilepsy. And soon appeared other studies, and again, the study from Cincinnati on 28 patients who were treated due to subependymal giant cell astrocytomas. In 16 of them, there were active seizures, and 9 patients experienced decreases in seizure frequency. 6 reported no change, while 1 patient experienced an increase in seizure. Still, this report was very promising in these drug-resistant seizures in patients with tuberous sclerosis. So after this study, there was designed another study, much larger study, EXIST-3. And in this randomized phase 3 trial, there was a group of 225 patients with tuberous sclerosis and drug-resistant epilepsy enrolled. And in this study, everolimus was given into 2 doses, 4 to 7 and 9 to 15 nanogram per milliliter in serum. And it was given as additional treatment, add-on treatment to the existing anti-epileptic drugs. And just last year, the results of this EXIST-3 trial have been published. And you can see here that even the lower dosage of everolimus gave us 28% responders, and the higher dosage of everolimus gave the positive effect in 40% of patients with drug-resistant epilepsy. So mTOR inhibitors are very effective in patients in tuberous sclerosis. It seems to be rather holistic treatment because there is a documented effect, very good effect on the renal angiomyolipomas. with the best response in this kind of tumors in patients with tuberous sclerosis. It's also documented effect on subependymal giant cell astrocytomas. There is a group, significant group of patients with drug-resistant epilepsy, which may also get a very good response in epilepsy with mTOR inhibitors. And we need to remember that these mTOR inhibitors are working on also other comorbidities, and further studies are ongoing, for example, on skin manifestations of tuberous sclerosis. It will be difficult to do, but also there are some reports about the positive effect of mTOR inhibitors in newborns with very huge, very large cardiac rhabdomyomas. But the assessment of this group is very controversial because of the cardiac rhabdomyomas regress spontaneously as well. So there is a significant progress in TSC diagnosis and management, and prevention of epilepsy in this group of patients is possible in large proportion of early diagnosed infants, and mTOR inhibitors changed prognosis for TSC patients. I would like to thank our patients and multiple contributors from neurology, neonatology, and fetal cardiology departments in Poland, and our partners from Epistop Consortium. Thank you very much for your attention.